Hello class, this is Cheryl Conley and I am going to be delivering your PowerPoint today on renal failure and dialysis. Dialysis is begun when the patient's uremia can no longer be adequately managed conservatively. Generally, dialysis is initiated when the GFR is less than 15 milliliters per minute. This criteria can widely differ depending on the clinical situation. Basically, it'll be up to the physician and the patient to determine when to start dialysis, and this is usually based on the patient's clinical status. Although dialysis is typically started when the GFR is less than 15 milliliters per minute, there are certain uremic complications such as encephalopathy or neuropathies, uncontrolled hyperkalemia, pericarditis, sometimes accelerated hypertension, which might need or cause an indication to start dialysis immediately, regardless of what the GFR actually says. But what you should know is that if the GFR is less than 15 milliliters per minute, the patient has to decide to do something, because if they do not, that is basically incompatible with life. So what is dialysis? Dialysis is basically the movement of fluid or molecules across a semi-permeable membrane from one compartment to another. We use dialysis to correct fluid and electrolyte imbalances and basically to remove waste products caused by renal failure. Sometimes you will see it in the emergency rooms to treat drug overdoses. Again, dialysis is when a patient's uremia can no longer adequately can be managed conservatively. And then this is a recap of what I just said at the beginning of the PowerPoint. There are two methods of dialysis that is available. We basically have peritoneal dialysis and hemodialysis. And so I'm going to talk to you about both of those types of methods of dialysis. The first one we're going to start off with is basically peritoneal dialysis. Peritoneal access is basically obtained by inserting a catheter through the anterior wall. It's a technique the technique for the catheter placement will vary depending on the facility that the patient is in. It is usually done via surgery while the patient is under general anesthesia. When you hear the prototype catheter, a tank-off catheter, know that that is basically a brand name. There are several different types of catheters. Like I said, there's the tank-off catheter. Some can use the Gore-Tex catheter, Toronto Western catheter. They're all basically the same thing. They're just made by different companies. So if you hear the term tank-off catheter or Gore-Tex catheter or Toronto Western catheter, just know that it is a type of catheter that is used for peritoneal dialysis. This is an example of a tank-off catheter. As you can see, the end of it, the tip of the catheter, lies in the peritoneal cavity. Also notice that there is something called a Dacron cuff, which is part of the tank-off catheter. And in the next slide, I'm going to show you an up-close view of that. But this becomes important because that helps to prevent migration of microorganisms down the shaft from the skin. So I'm going to show you that on the next slide. These are different types of peritoneal catheters. As you can see here, it is an exit. It exits out of the peritoneal cavity. Here is a Dacron cuff, which is part of the tank-off catheter. Know that this tank-off catheter or this Dacron cuff is seated with antimicrobials. So as it is placed into the patient, when microbes, it tries to stop the microbes from migrating down into this catheter and into the peritoneal cavity to prevent infections for the patient. Also notice that in this picture, if you take a look at this tank-off catheter, there are many different holes that are within this catheter. And so when the dialysis fluid is placed in the tank-off catheter, it travels down the catheter and it exits out many of these different holes. So the fluid doesn't just come out in one particular spot. It comes out and leaks out through many of these different holes in the tank-off catheter for the patient. With peritoneal dialysis, there are different types of systems. We do have something called an automated peritoneal dialysis, which where the cycler will deliver the dialysis fluid to the patient automatically. And then we also have a continuous ambulatory peritoneal dialysis system, or a CAPD. And so let me explain very briefly the different types of systems that we have. With the automated peritoneal dialysis system, like I said, the cycler will deliver the dialysis to the patient automatically. The patient is connected to a machine which controls the fill, the dwell, and the drain phases of the dialysis fluid to the patient. So basically the patient is at home typically, and they have their tank-off catheter which sticks out of their peritoneal cavity. They uncap it and they connect themselves to a peritoneal dialysis machine. And that machine will control the fill of the dialysis fluid into the peritoneal cavity. The dwell time basically is the amount of time that the dialysis fluid sits in the peritoneal cavity. And then it also controls the drain phases, or when it's time to drain the fluid out of the peritoneal cavity, it takes care of all of that timing. The other type of system is called the continuous ambulatory peritoneal dialysis machine. And basically this is where a patient does the manual exchange themselves. And so there isn't a machine that they are connected to. They take their tank-off catheter, which is basically sitting in their peritoneal cavity, and they unhook it and they connect it to a peritoneal dialysis bag. Then they take the fluid and they put the fluid into their peritoneal cavity. They control how long it dwells or sits in their peritoneal cavity, and then they control the drain phases, or when it's time to actually empty out the peritoneal dialysis. So automated peritoneal dialysis, it delivers everything based on the machine. The machine controls the time, the fill, the dwell, and the drain phases, but the only other difference is with continuous ambulatory peritoneal dialysis, the patient controls all of it, and it's a manual exchange. Some of the complications of peritoneal dialysis, basically exit site infection. Obviously, if anything enters the body, the patient is at risk for exit site infection. One of the things that can be very, very deadly to our patient is something called peritonitis. Obviously, that's an inflammatory or infectious process that happens in the peritoneal cavity. We can have abdominal pain in the area. We can have outflow problems. Patients can suffer from hernias as well, and low back problems, because the fluid that enters into the peritoneal cavity can be very heavy, and so it can be taxing on our internal structures. Bleeding can happen because of trauma from the catheter. And then pulmonary complications is something that you might not think about too much, but if you really do spend some time thinking about the pathophysiology, when the peritoneal dialysis fluid enters into that peritoneal space, it is space occupying. And sometimes the amount of fluid put into the peritoneal cavity is up to 3,000 milliliters of fluid. And so if we put about 3,000 milliliters of fluid into the peritoneal cavity, it will displace the diaphragm and the expansion of the lungs. And so everything gets pushed up because it is space occupying. And because the lungs may not be able to fully expand with all of that fluid in the peritoneal cavity, some patients are at risk for pulmonary complications. And that is one thing, obviously, that the nurse is going to have to monitor the patient for. Those patients who have underlying respiratory disease like COPD or emphysema are at greater risk for pulmonary complications because of the space-occupying dialysis that sits in the peritoneal cavity. These are some contraindications for peritoneal dialysis. If a patient has any of these, obviously they will not be a candidate for peritoneal dialysis. So there is, if they have a history of multiple abdominal surgical procedures or chronic multiple abdominal surgeries or procedures, it can cause a contraindication for peritoneal dialysis. If they have any abdominal pathological conditions such as pancreatitis or diverticulitis, recurrent abdominal wall or inguinal hernias, all because this dialysis fluid is very heavy and space occupying, so it puts our patients at greater risk for complications. If they have obesity and large abdominal wall and fat deposits, and of course because they are already predisposed to back problems, if they have a history of chronic back problems or pre-existing vertebral disease, they are not a candidate for peritoneal dialysis. Of course, if they have severe obstructive pulmonary disease, because I had just said this on the previous slide, that it puts them at greater risk for pulmonary complications, and so those patients with severe obstructive pulmonary disease would not be a candidate for peritoneal dialysis. So let's move on to hemodialysis. What the nurse needs to recognize or to realize is that when a patient goes for hemodialysis, we weigh the patient before they go down for dialysis. And what the nurse should recognize or realize is that for every 2.2 pounds or 1 kilogram of body weight that is pulled off of the patient, the nurse can expect to drain 1,000 milliliters of fluid during dialysis. So let me just say that in a different way. For every 2.2 pounds gained by the patient, the nurse can expect to drain off 1,000 milliliters of fluid during hemodialysis. So for example, if I weigh my patient before they go down for hemodialysis, and they have gained 3 kilograms since the last time they went to hemodialysis, the nurse should expect to drain about 3,000 milliliters of fluid off during that hemodialysis cycle. So again, for every 2.2 pounds or 1 kilogram gained by the patient, the nurse can expect to drain off 1,000 milliliters of fluid during hemodialysis. This is important to know because, when our patients are weighed, we should have some idea how much fluid that would be expected to be drawn off by our patients. Vascular access site. Obviously, the patient who needs hemodialysis will need some type of vascular access. And obtaining vascular access is one of the most difficult problems that a patient runs into who requires hemodialysis. There are different types of accesses. One is shunts. Another is our internal AV fistula and grafts. And of course, if they need vascular access in a hurry, we can do temporary vascular access. You should also know that internal AV fistulas and grafts and shunts require anywhere from 6 to 8 weeks of healing time before they can be used. And so therefore, some of our patients who come in who might have severe complications from renal failure, they may not have 6 to 8 weeks of waiting time in order for us to be able to do some hemodialysis on them. And therefore, they might need temporary vascular access. And so we'll talk about that in just a minute. These are our different types of vascular accesses, specifically shunts and internal AV fistula and grafts. the first picture here, you can find this picture in Lewis, and this is basically a shunt for a patient. It is external in the simple fact that this white particular portion here is on the outside of the patient. It is not underneath the skin. And as you can see, this particular shunt uses the radial artery and the basilic vein. And so it connects the radial artery and the basilic vein. So one side enters the arterial side, and then the other side enters the vein side. And so when the shunt area is accessed, the dialysis nurse will put one end of the needle into the arterial side, run it to a machine where it is cleaned, and then it is, once the blood is cleaned or filtered, it enters back in through the basilic vein to be entered back into the patient. The next type of arterial shunt or graft or access is called the AVF, or the arterial venous fistula. And what happens with this type of access is that there is an anastomosis which is performed for the patient. With this type of AVF, the radial artery and the basilic veins basically is anastomized during surgery, and so this is all internal, and the basilic vein and the radial artery are anastomized, and the blood is basically pulled off in the same manner that an external shunt is. An AV graft is basically a synthetic graft. It is like this shunt, except that this white portion does not stick out of the patient. It is internal, and so in an AV graft, the antecubital vein and the brachial artery are both used in this particular procedure. And again, this is just a couple of different vascular access sites. And so whether or not the doctor uses a shunt, an AVF, or an AV graft will be completely up to the physician and the patient to decide what is the best type of vascular access for that particular condition and that particular patient. Moving on to temporary vascular access. This is what you will typically see in the ICU or the emergency room. Again, because an AV fistula or a graft or a shunt takes anywhere from 6 to 8 weeks to be able to use, some of our patients are in dire medical need of dialysis and can't wait that long. So the doctor will perform a temporary vascular access site for the patient. With temporary vascular access, the physician can use either the internal jugular or the femoral vein for that particular access. Sometimes the subclavian vein is also used, but because of the anatomical position of having to cannulate the subclavian vein, the risk of a collapsed lung, for example, is higher. And so even though that might be what you see in the ICU, in the ER, know that they do use the subclavian vein, but most preferred, and according to your Lewis book, the internal jugular and the femoral vein is basically preferred over the subclavian vein, just because there is less complications of the IJ and the femoral sites. But again, like I said, you may see the subclavian vein typically used in the ICUs more than the IJ or the femoral areas. So let's talk about the complications of hemodialysis. Hypotension is a complication that can occur. And this should make sense that if we're pulling off sometimes 3,000 milliliters of fluid, in many cases it is an excessive amount of fluid to be pulling off very rapidly, and therefore the patient can experience hypotension. Know that blood pressure drugs should be held before dialysis for this particular reason. In fact, drugs that the patient usually takes on a routine basis, you may want to, as the nurse, call down to the dialysis floor to find out which medications should be given to your patients prior to dialysis, and then clarify with them what drugs, particularly blood pressure medications, should be held before dialysis. Which ones should be given, which ones should be held. Sometimes, you may not always know that from the get-go. Your best resource is either, pharmacy or the dialysis nurse. Know that muscle cramping can also happen as a complication of hemodialysis. It's usually caused by ischemia of the skeletal muscle that results from aggressive fluid removal. Know that the patient is at risk for dysrhythmias, and this is because a rapid shift in serum potassium can happen during dialysis, and then many times there is clearance of their normal antidysrhythmic medications that they are typically and routinely on. It's removed during dialysis, and so that puts them at risk for dysrhythmias. Loss of blood, and this is because some blood can be left behind in the dialyzer. Not very often, but just know that they are at risk for loss of blood because of this. Other complications, in the past, hepatitis would be a complication that we had to worry more about, but now that we do screen our blood for hepatitis, this type of complication has decreased. And usually, because of blood left in the dialyzer, and because of the fluid that was removed, sometimes our patients were at higher risk and needing blood transfusions, and so they were at higher risk for contracting hepatitis. But again, because we do screen for hepatitis, this has decreased this complication, but they are still at risk. Because there is introduction of organisms into the bloodstream, sepsis can happen with our patients, and that is true whenever we introduce or they have any kind of any kinds of catheters or anything like that, or invasive procedures. It can introduce microorganism. The next complication that the patient with hemodialysis might go through is something called disequilibrium syndrome, and this is due to the blood-brain barrier, which sometimes causes extra fluid in the brain. That tissue might create a state of cerebral edema, and then the patient is at risk for headaches, nausea, vomiting, mental confusion, and occasional seizures. Now, the pathophysiology on disequilibrium syndrome, sometimes urea and sodium and other solutes are removed more rapidly from the blood than from the cerebral spinal fluid and the brain, and this happens during dialysis. If that should happen, removing the blood more rapidly from the cerebral spinal fluid and the brain, this kind of creates an increase in osmotic gradient, which means that fluid would shift into the brain. And if fluid is shifting into the brain, it can cause a cerebral edema, which leads to the patient coming back with symptoms like severe headache, nausea, vomiting, mental confusion, and occasional seizures. And so therefore, it is a very real complication and something that the nurse will have to monitor their patients for when they come back from hemodialysis. Another complication, which is a rare complication, is that air can be introduced into the bloodstream through a break in the dialysis circuit. And so therefore, if air is introduced, of course the patient could be at risk for an air embolism, a very rare kind of complication, but still a real possibility, although very rare. So let's talk about something called CRRT, which is continuous renal replacement therapy. So we just talked about hemodialysis being a very fast and aggressive means of removing fluid and toxins off of the person's bloodstream. Normally, when we send somebody down for hemodialysis, that process can take anywhere from 2 to 4 hours. The patient typically has anywhere from 3,000 milliliters of fluid drawn off in 2 to 4 hours. However, most of our patients who are in the ICU can't tolerate that amount of fluid being drawn off in 2 to 4 hours. Because if we were to draw that amount of fluid off that very quickly, we can cause hemodynamic instability. And so there is an alternative to very fast hemodialysis. And the alternative or adjunctive method for treating acute renal failure for those patients is called continuous renal replacement therapy. This is a means by which uremic toxins and fluids are removed, but they are removed very, very slowly. So it is sort of like having hemodialysis, but on slow mode, okay? And so the patient is hooked up very much the same like they are with hemodialysis, and their acid-base status or their electrolytes are adjusted slowly and very continuously. And so the exchange of fluids happens very slowly, very steady process. Sometimes the patient is hooked up 24 hours per day, and this is done for 2 to 3 days, okay? And so again, with hemodialysis, it is where they take the fluid off very rapidly. It happens within 2 to 4 hours. And again, our patients might not be able to tolerate that because it can cause hemodynamic instability. And so CRRT is an alternative type of hemodialysis. And again, this is a very slow, steady process. They can be hooked up for 24 hours a day, and it can last anywhere from 2 to 3 days. And then the patient takes a break for a couple of days, and then the doctor may decide to do CRRT or continuous renal replacement therapy again for another 2 or 3 days. Okay, so oftentimes you will see this done in the ICUs. So again, commonly with CRRT, commonly used with the hemodynamically unstable patients, those patients who can't tolerate a very aggressive removal of fluid. With CRRT, very oftentimes the patient or the doctor will use a temporary double lumen catheter placed in the femoral, jugular, or subclavian vein. So let's talk about kidney transplantation. Usually with kidney transplantation is an extremely successful type of surgery. Know that our 1-year graft survival rates, that if they use a cadaver transplant, the graft survival rate is about 90%, and it goes up even more so. That graft survival rate goes up to 95% if a live donor is actually used for the kidney transplantation. Some advantages, obviously, of kidney transplantation compared with dialysis is that if it is successful, many of the pathophysiological changes associated with renal failure is eliminated. It eliminates the dependence on dialysis. Those patients that do go to a dialysis center, they spend anywhere from 2 to 3 days per week, and they spend hours at a dialysis center. And so this can really radically change a kidney failure patient's outlook on life, and again eliminates the dependence on dialysis. It is less expensive than dialysis after the first year. Believe it or not, it is less expensive than going to a dialysis center or having to have dialysis done. It is a very expensive procedure to have dialysis. Let's talk about the kidney transplantation recipient selection. And, this can be a very hot topic. It can be controversial in some cases. Trying to decide which patients out of a group of patients should receive a kidney, which ones get higher priority over another. And so the candidacy of the recipient selection is determined by a variety of medical and psychosocial factors. Usually this may vary among transplantation centers throughout the United States. Some of the things that are taken into account are contraindications to transplantation, and so listed on the board here are some contraindications to even being a recipient to kidney transplantation. So If a patient has disseminated malignancies, cardiac disease, or pulmonary insufficiency, because the kidneys are a very vascular organ, if the patient has extensive cardiac disease and pulmonary insufficiency, they won't be able to support that new organ. If they have chronic respiratory failure for the same reason or extensive vascular disease, they will not be able to support a new organ and will not be a candidate for transplantation. If they have chronic infection for the same reason, also if they have unresolved psychosocial disorders, because there is a risk for rejection of the kidney. If they have any psychosocial factors that would push them over the edge, so to speak, we don't want to take the risk of putting in a new organ and having it be rejected and then have them have psychosocial problems. And so they need to be psychologically stable or deemed psychologically stable before they can receive a kidney. Know that hepatitis B and C, if they have that in their history, it is not an automatic exclusion factor for them. Okay, so if they have hepatitis B or C, we do screen for that, but it is not an automatic exclusion factor. Also know that substance abuse is not an automatic exclusion factor. Usually the patient will have to go through a screening process, and if they usually a contract is signed to keep them on a waiting list, and so long as they are showing that their drug screen is clear and that sort of thing, they can stay on that waiting list. But if they should happen to break their contract, they are taken off the list if they don't uphold their portion of the contract. The kidney transplantation surgical procedure, you can read about this in your Lewis book. I'm just very briefly going over this because many students and even nurses don't realize this. When a patient gets a kidney transplant, it is usually placed extraperitoneally in the iliac fossa. The right iliac fossa is preferred. What most nurses and students don't realize is that the patient ends up with 3 kidneys, 2 of their own and 1 of their transplanted kidneys. They don't take out the 2 kidneys that are not doing their job. They feel that by taking them out, it puts the patient at higher risk for complications. So they just leave the 2 in, and then the 3rd kidney, or the kidney that's being transplanted, ends up in the patient's right iliac fossa. And so here's a picture of a transplanted kidney that is in that right iliac crest area. And if you want to read about the actual procedure that is done, you can read about that in your Lewis book. But basically, the internal iliac artery and vein and the external iliac artery and vein are anastomized and replanted in order to support the new kidney. Okay, so knowing that, moving on to immunosuppressive therapy, obviously with a kidney transplantation, the goal is going to be to adequately suppress the immune response and to help maintain sufficient immunity to prevent overwhelming infection. And so know that with immunosuppressive therapy, those patients that have had a kidney transplantation, they are on immunosuppressive therapy for the rest of their lives, for as long as they have that kidney. And so it is a lifelong goal to help prevent overwhelming infection or to suppress the immune response. So they will be on that medication for life. Some of the kidney transplantation complications after they get their kidney, of course, rejection of that actual organ is a very real complication. Know that with hyperacute rejection, it can occur minutes to hours after a transplant. A patient can have acute rejection, which occurs days to months after a transplant, or they could have chronic rejection, where they get that kidney transplant and the process occurs over months or even years, and then they end up rejecting that kidney, which can be very, very sad and detrimental, to the patient in terms of their psychosocial well-being. And so that ends my PowerPoint on dialysis. And so I've got the little slide up here that says, now don't you appreciate your kidneys, between the acute management of renal failure to the chronic complications of renal failure. Those organs are, they just do a lot for us. And so don't you appreciate your kidneys? Be sure to thank them. That ends my PowerPoint.